Welcome to Washington Hospital Today, dedicated to informing residents about healthcare topics and issues. Through programs featuring community forums and free health and wellness classes, our goal is to empower community members with the information needed to make informed health decisions. Washington Hospital has been providing healthcare to the residents of the Washington Township Healthcare District for the past 60 years.
Hello, welcome to today's presentation, Trauma Program Update, presented by Dr. Chet Morrison, Medical Director of the Trauma Program at Washington Hospital Healthcare System. Dr. Chet Morrison has been with Washington Hospital since January of 2024, where he contributed to the opening of our Level 2 Trauma Center in July of 2024. Prior to this, he was an Associate Professor of Surgery at the Central Michigan University School of Medicine and Trauma Medical Director for St. Mary's Ascension Hospital in Saginaw, Michigan. He is board certified in surgery and surgical critical care and has been an attending trauma surgeon for 23 years. Dr. Morrison has extensive experience in the United States Army Medical Corps, deploying to Colombia and Iraq as a military trauma surgeon, where he received several military decorations, including a Bronze Star and the Expert Field Medic Badge. He is also involved in leadership roles in several regional and national professional organizations, including ASPEN, Society of Critical Care Medicine, and the American Association for the Surgery of Trauma. Please welcome Dr. Chet Morrison.
Hello, and welcome to the presentation. As the introduction said, I'm Dr. Morrison. I'm the Trauma Medical Director for the Washington Hospital Healthcare System Level 2 Trauma Center. And I'm going to be talking about why we have trauma centers, what the trauma center consists of and why it's important, and perhaps a little bit of what you can do to stay safe and support us. So if I can have my first slide, I want to go over the nature of the problem. In the state of California, trauma is the primary cause of death for people ages 1 to 44. And that's actually reflected in the national figures as well, where up until age 44, it's the #1 cause of death, regardless of gender, race, or economic status. And furthermore, it's also the biggest cause of what we call years of potential life lost. In other words, what people would have done and how long they would have lived had they not gotten injured. Given the magnitude of this problem, there was the push, which I'll discuss, to create trauma centers which we could provide care to patients when they're acutely injured, and also maybe decrease the number of people that we lose from unintentional injury. Right now we have 81 designated trauma centers in the state of California. And again, just in the state, over 70,000 trauma patients get admitted per year. And these are folks who are acutely injured and need care. We have a mixture of public and private entities in the state. And one of the things we do, as I'll touch on in the end, is we work very hard to try and reduce the burden of injury in the population here. We work with emergency medical systems authorities, and they're the ones that certify us. They've been designated as our authority by the California legislature, and we all work together to provide care to people. And they help us in the planning of where the trauma centers go and who they admit. To delve into a little bit of history, it was actually in the 1966 where the National Academy of Sciences released an accidental death and disability, wherein, because of the fact that people were getting more mobile, the population was increasing, it became increasingly clear that injury was a serious rather than an episodic problem and merited a coordinated response. Then, following this along, there were several systems developed to take care of the injured patient. Something that's not on the timeline is we've kind of figured out a good pattern to take care of people when they're injured, one that would work everywhere. And subsequent reports, as you've seen, have sort of emphasized the fact that this is a problem that needs continuing effort, not just in the hospital care, but also in prevention. The latest one I point out is a 2016 report by the National Academies of Science, which was sort of the body that made the first report, the integrating military and civilian trauma so that we could bring the lessons learned from wartime care, and I was involved in that a little bit, to the civilian population. So again, all our population, all our patients got the best care, including the benefit of some hard-won lessons that we learned on the battlefield. Alongside of this was the concept of the golden hour. In other words, that you had a certain very limited amount of time, but if you intervened during that time, your patients would do better. And Dr. Cali was one of the pioneers. I put his slide up here because he is actually the founder of the institution in which I trained, one of the premier trauma centers back east. And there were also a couple of other pioneering trauma centers, one in Chicago, one in San Francisco, besides the one he founded. And those were the first centers to actually say, hey, let's actually concentrate on the trauma patient. Let's integrate the knowledge that we had. And that way, let's get everybody together working as a team. And that way, actually, we can provide the best care. And then, therefore, you get the best outcomes. And here's a concept that I would say that I think makes it clear for everyone. When you look at how trauma patients die, you have patients that suffer immediate deaths, and this is actually kind of true in the battlefield as well as in the civilian sector, where you have some patients that will die at the scene, and unfortunately, there is little that medical science can do for them. Those are things that would be handled by prevention, and that's why we are very committed to trauma prevention events. As you see on the latter part of the slide, if you look over the right part, there are late deaths that happen in 2, 3, 4, 5 weeks, which previously were things like infection and organ failure. And then the graph that we concentrated on was the early deaths, the ones you see in the center of the slide, where within a few hours some people were dying, and we thought that those deaths were preventable. And by having a trauma center and the team of people that take care of patients as soon as they come in, we could flatten that early deaths curve. And we've actually found that not only is that so, that we can flatten that curve, but we can actually also affect the late deaths as well, such that we don't get that late deaths curve anymore because of the intervention that we've done in the first few hours trying to prevent the early deaths. So moving along, given the fact that we've shown that trauma patients really benefit from care being delivered to them right away, if you look at the map, there's an area that there was an unmet need for trauma centers. And it's sort of stated here in blue is southern Alameda County, in which you'll see that there's a gap between the other trauma center, which was a red dot, which is in Castro Valley, that's Eden Medical Center, and one to the south of us, which was Regional Medical Center in another county. And so what that meant before the opening of our trauma centers, that if you got injured in that blue section of the map, you'd have had to be taken to one of these two hospitals. And as you can see, there is some distance involved, and plus we all know, how much fun Bay Area traffic can be. Sometimes there was actually a traffic barrier to go through as well. So from this is one of the reasons that the area of the country where we're located in would benefit from a trauma center, which is why we opened up. And when we open up a trauma center, as you can see here, there's a big commitment of resources. In fact, the American College of Surgeons certifies trauma centers, and what that means is their experts and leaders in the field come out to trauma centers and make sure that they have what it takes to take care of people. They have the support, they have full-time coverage by a trauma surgeon, they have the other specialty surgeons that you need, they have the support in terms of radiology, they have medical specialists, they have an operating room that's available all hours of the day at night, blood bank that's available. And the last thing is we have a process improvement where we look at the way we take care of people, we look at what went right, we look at if things didn't go right, and from there we try to make improvements. So we have a kind of a continuous positive cycle where we take care of patients, we learn how to take care of patients better, we take care of patients better, we look at that, and ideally we look at processes with other trauma centers so that all the hospitals and all the trauma centers around the area have a good way of taking care of people. What that looks like in practice is something like this. This is actually not the interior of our trauma center. This is another one that I got, but the concept is the same. And the initial bays in trauma centers don't actually look that much different. You have a gurney in the center where patients are brought on. You have a team that evaluates the patient right away that you can see. There's a leader at the head. The trauma surgeon is there, where our nurses, our support personnel are there. We get radiographs, we put in orders. And the other thing is that it's surrounded by cabinets and refrigerator where we have our equipment and we have blood, so that we don't have to go scurrying about for equipment. It's right there in the room. If we need something to help in the resuscitation or help in care, it's right there. If we need IV fluids, it's right there. If we need blood, it's right there. And again, that way we can, shorten the time as much as possible for patients to get care when they come in injured. I'd also add, and I'll go over this on a slide, there's several levels of activation, such as the highest level, which is something you're seeing in the picture, gets the biggest response. So when patients have signs that they're very critically injured and they're going to need intervention right away, that's when we mobilize the full team. Here's our team. This is actually myself and my colleagues. These are some of the banners that we have actually hung outside the trauma center. And we do this to show that we are fully staffed. We have our surgical specialists. This is myself and my colleagues. One of us who is on call all the time. And we have a mixture of fellowship trained and long-standing community surgeons with decades of experience in the field. So we think we provide a pretty good product. And we're locally integrated in the community. And I actually think that because of this, the area of the country was well suited to become a trauma center, because we had a pool of talents that we could tap into to help us in our endeavors. And it's been nicely demonstrated by our newspapers. This came from July, where we actually opened up and we hit the ground running. And they made a point of that in that article, that basically as soon as we opened up, we started getting injured patients, and the numbers were not inconsiderable. There was clearly a real need for our services. And as part of what we're doing here, because of the fact that we want to provide state-of-the-art care, we want to have the latest equipment to take care of our patients, we actually fundraise. And I'll go into this in a couple of minutes, where we have some equipment that we're going to be purchasing and ways to take care of patients even better. One of the things, just to go back to our numbers and look at, this is a graph of what we did. This is the first 3 months, in July, August, September of 2024. And although there may be a gap between when we got this data and when you're actually hearing me talk on the presentation, I don't think this is going to decrease by much. Again, because there's an obvious need for trauma centers in this community. And what I want you to get out there is this is our levels of activation, where depending on how injured we think people are, is how much resources get mobilized. But everybody, regardless of the level of activation, gets evaluated. They get their diagnostic studies, and the injuries that we find get treated. And as you can see, the numbers they're fairly considerable. And they roughly average anywhere between 130 and 150 a month, meaning that we expect that even if there's a slight decrease in the winter months, we'll do about 1,400 activations, which is to say at least 1,400 people per year are going to be injured and are going to benefit from the services that we offer. Some highlights, and these were things that we had to do to bring the hospital, and I'll add here that Washington Hospital was a well-established community medical center that provided care to the community for decades before it became a trauma center. But some of the things that we did for the hospital to increase its capacity is the personnel expanded. We hired people. There is a support staff, as I previously mentioned, that goes with every trauma patient. We have a trauma program director. We have our liaisons who look at the specialty care we provide. And we have a way of tracking our patients' outcomes so that we know we're doing a good job, and we also see areas of improvement. We have enhanced radiology capability. Again, those x-rays, those CT scans, which a lot of trauma patients get, those MRIs, which I'll talk about in a second, we actually brought those on. We have ongoing educational efforts, and when we say education, that means education at every single level. Educating the fellow providers and physicians, educating the nurses and nursing staff, the support personnel, educating our county partners who bring us patients and help us in terms of planning trauma centers, and also educating the civilian population, our patients and public, about prevention efforts that we do and what they can do. We present at local and national meetings. Like any other field, trauma has its professional organizations that we present at, and I'm happy to say we're already integrated into the association, the trauma centers around the Bay Area of California. Their educational efforts where we share best practices and cases, and generally sort of function as a consortium to offer best care to everybody, no matter where you are in the area. And as I speak, we've had our county 90-day review because we've been open as a trauma center and how that integrates into our trauma system, and that's going well. Some future efforts, I thought I'd point out that we're going to be getting our 3 Tesla MRI. And what that is, it's a very complicated machine that uses a very, very strong magnetic field. Doesn't use any radiation like CT scans or X-rays, but it uses a magnetic field and radio waves. And because of that, you get a signal which you can actually translate into some very good pictures that show you what's going on. And the thing with the strength of the magnet is it doesn't, it's not quite as claustrophobic as it was before. You don't have to go into a metal tube. It's a little quicker sometimes, and sometimes the pictures that you get out of it are better. And in fact, we actually had a fundraiser recently in which we actually got some very welcome community support to get that piece of equipment. Another one which I can't resist adding that's a plan for our trauma center is a hybrid operating room, which kind of brings together the best of surgery, orthopedics, and interventional radiology. So it's a room where you can basically do everything at once, and you don't have to take a patient from one room to another. If you need to do a blood vessel study and an operation and fix a fracture, you can do it on that one room, and it's very nice. It's a considerable expansion and considerable investment of resources, but it's really good for providing immediate on-the-spot care, and you can actually be life-saving. So those are some of the things that we have done, but the last thing I want to talk about is some community outreach, because every trauma center actually by requirements is supposed to be going out with the community and educating. And this bears fruit in terms of prevention efforts and also general public awareness of what trauma is. So some of our campaigns have been the Stop the Bleed campaign, which is a way we have of educating people to stop bleeding, and then as soon as you stop bleeding, people do better. So it's a way that they can get people to the hospital still alive, similar to providing CPR, pulmonary resuscitation, and chest compressions in the field. We do an anti-choking effort, just teaching the Heimlich maneuver, which is life-saving if people are choking and has been used to save lives. We do water safety. We recently spoke at the RNA Foundation Walkathon, which is very concerned with beach safety and water safety and drowning prevention. And water trauma is part of what we get. It's not a huge part, but it is certainly a part of trauma. And like any other aspect of trauma, we make some efforts for prevention. And there's skilled nursing facility fall prevention. Falls are actually a very common mechanism we get. As I like to say, gravity comes for us all. And so we see a lot of falls. And so again, the more we can work to prevent falls, the better we do. In terms of our Stop the Bleeding, that's one of our community efforts. And I just, we give classes on this. I just wanted to put a sample slide that we teach people to apply pressure, to recognize life-threatening bleeding and apply pressure. And if you can apply pressure, you can usually stop most bleeding in an arm or leg, and then that way people can get to the hospital where we can stop it definitively. And since the bleeding has been stopped, they do better. The other part of that course is we actually teach people how to apply tourniquets. And although tourniquets have their uses and complications if they're put on for a long period of time, if they're put on for a short period of time, they're actually very effective in stopping bleeding, and that gives us the time frame to get people to the hospital, where again we can stop the bleeding definitively. So all our first providers carry tourniquets, and I actually think they're useful things to have. And we also teach them, we teach people how to apply them properly. One of the things that the legislature in California has recognized this, and in fact, AB 2260 actually required trauma kits, and part of that are those tourniquets and dressings I've mentioned, because that's the thing that people can do, is stop bleeding. You can't stop bleeding everywhere, but in a lot of places you can stop bleeding. And so the California legislature has said that large buildings will have these kits. But like any other kit, it only works if people use it and know how to use it. So that's a step, but that again goes to our efforts for trauma education. What we can do? Well, part of what we can do is recognition. One of the things about motor vehicle crashes is they still happen, and the reason is because people will still do behaviors that increase the risk of automobile crashes and injuries. And so many of those can still be avoided by taking time to make good decisions, which we advocate for, remaining alert for driving, and not being distracted. And I wanted to say something. This is a health and wellness seminar, so I couldn't resist throwing a little prevention efforts about distracted driving. It actually is a problem because people do die from distracted driving, and the injury and death burden is still considerable. And the thing with distracted driving is it's pretty much preventable, okay? Do not get distracted when you're driving. Texting, operating the dashboard infotainment center. To some extent, I'm not sure the automobile manufacturers are really helping us with these infotainment centers that they put in. Searching for something that falls on the floor. It's the situational awareness that you're operating a moving vehicle at high speeds, and you really need to concentrate on that. And we think that with efforts, we can make the same impact that we have of drunk driving, which, although it's still a problem, is much less of a problem with the past 30 years falling, and due to prevention, legislative efforts, and I think just general awareness that most people know that drunk driving is not good, that you shouldn't do it. So that sort of gets along, just like people realize that you should wear your seatbelts for the same reason. You have a much better chance of surviving. Make sure all the passengers are restrained securely. One of the things that's not on that slide, but I might recommend, is just sort of also following speed limits and traffic signals, the way they teach you in driving school. And one last thing too, and this is actually, I find notable in this area, is that pedestrians are at risk. So you should always kind of keep your eye carefully on the pedestrians. And when you are a pedestrian, keep your eye carefully at the cars. And don't drive distracted, don't walk distracted, because when there's a collision between car and pedestrian, it is bad for the pedestrian, no matter whose fault it is. Wearing something, if you're walking around at night, wearing something reflective is also something I think that I kind of recommend. It makes you much visible, and it's really helpful. What are our next steps? I'll close about here because, as I said, we had opened up in July 2024, and we expect going forward that we will be looking at our reviews. The American College of Surgeons reviews trauma centers, and they do that on a 3-year cycle, and they actually review all the trauma centers in one area sort of at one time. So what we're going to do is we're going to get preliminary reviews in 2026, and then in the spring of 2027, which is to say 2.5 years from now, we'll get our American College of Surgeons verification review. Once that happens, we're officially a level 2 trauma center. And when they do the review, they're going to be carefully looking at how we take care of patients in the prior review cycle, the things that we do well, the things that they think we can do better on. And it's actually a way of, again, always increasing the ability of our trauma centers to take care of our patients. This finishes my presentation. I thank you for your attention, and now I think we can move to the part of the presentation where I answer a couple of questions.
Thank you, Dr. Morrison. We do have a few questions. The first question is, what are the most common trauma cases that our trauma center has treated since opening?
Since opening, the most common has been falls. I think I mentioned in my presentation that gravity comes for all of us. And so we get a lot of falls. We get falls from ladders. People go up there doing something on the roofs, falling down. We get falls from stairs. We get ground level falls, which sound trivial until you actually do a ground level fall yourself, and then you have a sort of a real respect for that. So those are our number one falls. The other things that we get not uncommonly are motor vehicle collisions. That's number two. We get some motorcycle collisions, just automobile accidents of all sorts, and that also includes people being hit by cars. And those are also not uncommon. And then after those two, you get sort of a miscellaneous ways of how people hurt themselves. And that includes some gunshots and some stab wounds, assaults and things like that.
How is Washington Hospital educating the community on how to prevent or avoid traumatic injury?
Well, I kind of went over that in the presentation a little bit, and this gives me the chance to go into some detail. We run several Stop the Bleeding classes. We reach out to schools and we reach out to institutions and run those classes. We presented at the RNA Foundation, and we expect that to be a yearly thing. We also reach out to nursing homes and do some things with fall prevention, and we had a nice event already since we've been open in one of the local restaurants about choking prevention. It's like, well, okay, that would be a good place to do choking prevention in a nice restaurant where you're enjoying the food. It's actually kind of one of my favorite long-standing jokes, in that trauma is actually one of the few professions that have a lot of education, time and investment in it, that work very, very hard at trying to put itself out of business. Not many businesses or professions that try to do that, but we try to do that, and those are our efforts. We try to, make our lives, in a sense, we're trying to make our volume as low as possible, while at the same time realizing that traumatic injuries are going to occur and we have to be ready for them.
This concludes our program. Thank you so much, Dr. Morrison, for this insightful presentation. And thank you, viewers, for tuning in. The entire broadcast of today's presentation will be available on our Facebook page and YouTube.